Okay, let's unpack this. Welcome to this highly focused deep dive. Our listener today, you're a learner who needs a really comprehensive, organized walkthrough of a huge body of knowledge. Chapter 51 from Brunner and Sutter's Medical Surgical Nursing, and we're focusing entirely on female reproductive disorders. So our mission today is to be your ultimate study session shortcut. We're going to synthesize all the clinical essentials. I mean, everything from, microscopic infections all the way to complex malignancies and major surgeries. And we're following the textbook structure, step by step, to give you that clinical context you need to make it stick. And we get that these disorders range so widely, right? From minor inconvenience to something truly life-threatening. So as nurses, you have to be sensitive and just really, really knowledgeable across that whole spectrum.
Exactly. And what's so fascinating about this chapter is just how clearly it organizes such diverse material. You're going from the pH balance of the vagina all the way to complex oncology management. So our job is to connect the why, the pathophysiology, to the what you do, which are the nursing interventions. And we're using that nursing process framework just like it's laid out in the book. So we're going to dive in first with the most common issues, things you'll see all the time. Vulvovaginal infections. And to get what goes wrong, we first have to understand the body's natural defenses. It's a pretty remarkable system.
Okay, let's start there with that natural defense system. You called it an ecosystem, and it sounds like pH is the gatekeeper. So what's the key protective mechanism?
The whole frontline defense is all about maintaining a really low acidic vaginal pH, usually somewhere between 3.5 and 4.5. And the key player, the star of the show, is a bacterium called Lactobacillus acidophilus.
Okay, lactobacillus.
It's absolutely critical. It takes the glucose and glycogen that are naturally in the vaginal lining and it produces lactic acid. That acid is what keeps the environment hostile to pathogens. And on top of that, it also produces hydrogen peroxide, which is toxic to a lot of the bad anaerobes that might try to move in.
So if that low pH is like the 247 security guard, when does the system fail? What lets the bad guys in?
It generally fails when resistance is down, from stress, illness, that kind of thing, or when that pH balance gets directly messed with by some outside factor. And chart 51-1 in the book gives a fantastic list of risk factors. These are things you need to be teaching your patients about.
Let's pull out a few of the big ones because they tie right into common medical practice and lifestyle. I mean, the first one that jumps out is long-term antibiotic use.
That's a huge one, a really common clinical scenario. You prescribe a broad-spectrum antibiotic for a sinus infection, but it's not picky. It wipes out that protective lactobacillus right along with the strep throat, and that creates a vacuum. It just leaves the door wide open for opportunistic things, especially yeast, to overgrow.
And then you have the hygiene and mechanical factors.
Exactly. We have to talk about poor hygiene, but what's really critical is douching. So many women think it's a good cleansing thing to do.
Right.
But it's not. It just eliminates that normal flora and it changes the pH. And then you've got things like tight synthetic clothing that just traps heat and moisture and it creates this perfect little incubator for pathogens. And then, of course, systemic things like diabetes. The high sugar is fuel for yeast or low estrogen states like menopause, which thins out the vaginal lining.
Before we get into the big vaginitis types, we should quickly touch on the Bartholin glands. They're right near the vaginal entrance. What's the difference between a cyst and an abscess here, and why is it so painful?
So a Bartholin cyst is just a blocked duct. The fluid gets trapped. But an abscess, which is way more painful, is when that trapped fluid gets infected and you get this acute collection of pus.
Ouch.
And the pain is so intense because of the location. Any swelling down there puts this incredible pressure on all the surrounding tissue, making it almost impossible to sit or walk.
Okay, so let's move to the big three infections from table 5101. We'll start with candidiasis, the yeast infection. It's the second most common complaint, right?
It is. It's caused mostly by Candida strains, and C. albicans is the culprit in about 90% of cases. And the pathophysiology is exactly what we just talked about. It's a flora imbalance. The fungus just takes its opportunity when the lactobacillus is suppressed.
And what are the big triggers for that?
The key triggers are things like pregnancy, uncontrolled diabetes, HIV, using corticosteroids, and often high estrogen oral contraceptives.
And the clinical picture is pretty classic, isn't it?
Oh, absolutely. The main complaint is intense pruritus, just severe, maddening itching and irritation. And it comes with this very distinct discharge. It's classically described as white, thick, and like cottage cheese. The symptoms also tend to get worse right before menstruation.
And how do you confirm it in the lab? It's not just a guess, right?
Right. No, you need a microscopic wet mount. Specifically, you use a potassium hydroxide slide, a KOH slide.
Hmm.
The KOH dissolves all the other cellular junk, which makes it way easier to see the fungus's structure. These long, branching filaments called hyphae and the spores. And with yeast, the pH is usually still pretty low, under 5.
Management is antifungal agents, miconazole, fluconazole. But there's a really important nursing caution here, especially if it keeps coming back.
A huge one. You have to caution women against just constantly self-treating with over-the-counter stuff if it's a recurrent problem. Recurrent candidiasis can be a red flag for something bigger, like undiagnosed diabetes or some kind of immunosuppression. They need a full workup, not just another tube of cream.
Okay, next up is bacterial vaginosis, or BV. This one's different. It's not really a fungal invasion. It's more of a massive shift in the whole bacterial neighborhood.
That's a great way to put it. BV is an overgrowth of all these anaerobic bacteria, and critically, an absence of the protective lactobacilli. And while it's linked to sexual activity, it's not technically an STI. It's an alteration of the normal flora.
So what are the big symptoms here, since it's not usually about the itching and pain?
The symptoms are less irritating, but still very noticeable. The discharge is usually grayish-white, kind of thin, but the classic telltale sign is the fish-like odor.
Right, the odor.
That odor is caused by amines produced by the anaerobic bacteria, and it gets way more noticeable after sex or during menstruation because the pH goes up a little bit.
So the diagnosis is really clinical then, based on that.
It is. The pH is almost always greater than 4.7, and the exam includes the positive whiff test. When you add KOH to the slide, it releases those amines, and you get that strong smell. And then microscopically, you're looking for clue cells, vaginal cells, that are just totally coated in bacteria, making the borders look blurry.
Management is metronidazole or clindamycin. But a key point here is that partner treatment isn't necessary, unlike with STIs.
That's right. Treating the partner is not effective for preventing it from coming back in the woman, though using condoms might help. The big thing with metronidazole is you absolutely cannot drink alcohol while you're taking it.
Which brings us to trichomoniasis, or trich, which is definitely an STI, caused by a protozoan.
Yep, Trichomonas vaginalis, a flagellated protozoan. It's a really common STI. And when people get symptoms, it's usually intense irritation. The discharge is really unique. It's thin, very malodorous, and it's often this yellow to green color and frothy or bubbly.
And the exam findings are also pretty specific. I've heard them called strawberry spots.
Yes, on a speculum exam, you might see these tiny little petechiae or pinpoint hemorrhages all over the cervix or vaginal walls. That's a sign of severe inflammation. The pH is always high, over 4.5, and since it's an STI, treatment is mandatory for the patient and all of their partners.
So what are the crucial teaching points around the medications, the metronidazole or tinidazole?
Both the patient and all of their sexual partners have to be treated. And the absolute critical teaching point is that disulfiram-like reaction with alcohol. No alcohol during treatment, and for at least 24 hours after metronidazole, or up to 72 hours after tinidazole. The reaction is miserable, nausea, vomiting, flushing, and they should also abstain from sex for about 7 to 10 days to make sure it's fully gone.
Okay, before we get to the full nursing process, let's just quickly cover the conditions that affect older women, specifically atrophic vaginitis.
This is a direct result of menopause. Low estrogen levels make the vaginal mucosa get really thin. It atrophies. The symptoms are a mild discharge, burning, and itching. And because the lining is so thin, there's less glycogen for the lactobacilli, so the pH goes up, making it easier to get other infections. The management is usually estrogen, either oral or a topical cream.
And then there's the more severe but less common disquamative inflammatory vaginitis.
Right. You usually see this in perimenopausal women. It's a severe purulent infection. It causes a lot of inflammation, discharge, burning, and really painful intercourse.
Okay, let's apply the nursing process to all of this. This is where really sensitive, detailed assessment comes in. What are the key priorities for the nurse?
Okay, first things first, the procedural instruction. You have to tell the patient not to douche or use any vaginal meds for at least 24 hours before their exam.
Because it washes away all the evidence.
Exactly. It removes the discharge you need for the diagnosis. Then the history is where you find all the clues. You need to ask about hygiene soaps, douching, underwear. You ask about medications, especially antibiotics. You explore their endocrine status. Are they diabetic? And you have to ask about psychogenic factors, stress, fear of an STI, and of course, any changes in sexual partners.
And this leads to preparing the smear, which is different depending on what you're looking for.
That's right. The nurse helps prepare 2 different wet mounts. The first slide gets a drop of saline. That's where you'll see motile things like trichomonas or the clue cells from BV. The second slide gets a drop of 10% KOH. That's the one that dissolves all the background stuff, so you can clearly see the branching hyphae of yeast. It's also the slide you use for that whiff test.
And once you have that diagnosis, the goals are really focused on comfort and education.
Right. The main nursing diagnoses are things like discomfort, anxiety, risk for infection, and deficient knowledge. So your goals are all about symptom relief and making sure the patient has the knowledge they need to take care of themselves and prevent it from happening again.
So let's talk about those interventions. What are some practical things for comfort and patient empowerment?
Comfort measures are pretty simple, but they work. You can recommend sitz baths, teach the patient to use a hairdryer on a cool setting to keep the area dry. And then education is where the nurse can make the biggest difference. You need to stress that a yeast infection is not an STI. That relieves so much anxiety right away.
That's a huge point.
It is. Then you teach prevention. Wear loose, cotton underwear. And you tell them again, douching is unnecessary, and it's actually counterproductive. For women using vaginal medications, you have to be super specific. Wash your hands, lie down for 30 minutes after you insert it, and use a pad for any seepage.
And finally, the chapter really emphasizes vulvar self-examination, or VSE.
Yes, nurses need to be promoting this. It's all about empowering women to know their own bodies, to know what's normal for them, so they can spot anything new or different right away. Persistent itching, a new lesion, a lump, those things need to be reported to catch any problems, including cancer, as early as possible.
Okay, let's shift focus now to infections that are primarily sexually transmitted. You have to start with human papillomavirus, HPV. It's the most common STI in the U.S. by a long shot.
It's incredibly prevalent. We're talking 79 million Americans. And it's a spectrum infection. It can be latent, so just DNA. It can be subclinical, so you can only see it with special testing. Or it can be clinical with visible warts or condylomata.
And the pathophysiology is so important because it's all about cancer risk. We have to talk about low-risk versus high-risk types.
That distinction is everything. The low-risk types, like 6 and 11, they're the ones that usually cause the genital warts. They're annoying, but they rarely become malignant. The really dangerous ones are the high-risk oncogenic types, especially 16 and 18. They cause about 2/3 of all cervical cancers. They actually integrate into the host cell DNA and cause abnormal changes, or dysplasia, which is what we're looking for on a pap smear.
Management for the warts can be a few different things.
Right. The provider can use chemicals like trichloroacetic acid, or they can freeze them with cryotherapy or surgically remove them. Patients can also apply some topical creams themselves. The big safety point here is that some of these agents are contraindicated in pregnancy. And no matter what, annual pap smears are non-negotiable because those high-risk types can be causing trouble even if you don't see any warts.
But the ultimate prevention is the vaccine. What's the current recommendation for that?
The ACIP recommends the 9-valent HPV vaccine for boys and girls around age 11 or 12 with catch-up until age 26. And the dosing is a little nuanced. If you start before you're 15, you only need 2 doses. But if you're older, or if the 2 doses are given too close together, you'll need a 3rd dose to get full protection.
Okay, next is herpes virus type 2, HSV2. This one is recurrent, lifelong, and often transmitted without anyone knowing.
The stats on that are really sobering. Something like 87% of people with it don't know they have it, so asymptomatic viral shedding is how it spreads most of the time. HSV2 is usually genital, while HSV1 is usually cold sores, but you can see crossover. And pathophysiologically, the virus travels up the nerve and then just stays dormant in the nerve ganglia.
What are the common triggers that can cause a recurrence?
Usually it's some kind of physical or emotional stress, a bad sunburn, being sick, poor nutrition, not enough rest. The lesions themselves follow a very classic pattern. It starts with itching or pain, then you get megalas, papules, vesicles, ulcers, and finally crusting over.
And since there's no cure, management is all about symptom relief and suppression.
Exactly. We use oral antivirals, acyclovir, valacyclovir, to suppress symptoms, make outbreaks shorter, and reduce how often they happen. And a key point for pregnant women, if there are active lesions near the delivery date, a C-section may be needed to protect the baby.
So for the nursing process, chart 51.2 has some great interventions. Relieving pain seems to be primary, especially the dysuria.
Oh, the dysuria can be excruciating. So besides analgesics and sitz baths, the most effective nursing intervention is to teach the patient to pour warm water over their vulva while they're urinating. It dilutes the urine and just stops the intense stinging.
And preventing spread is more than just abstaining during an outbreak, isn't it?
Yes. Patients have to use condoms even when they're asymptomatic because viral shedding can happen anytime. Good hand hygiene is so important to prevent spreading it to other parts of the body, especially the eyes. And, the nurse has to address the anxiety. This is a lifelong diagnosis, and that's a heavy thing to process. Support groups can be really helpful.
Okay, moving up the reproductive tract now to infections like endocervicitis, often caused by chlamydia and gonorrhea.
Right, endocervicitis is just inflammation of the cervix. If you don't treat it, that's the entry point for the infection to ascend. Chlamydia is the most common STI, and it's often silent, asymptomatic.
But the real danger with these two is the long-term complications, especially for fertility.
Absolutely. They are both major causes of pelvic inflammatory disease, or PID. PID causes tubal scarring, which massively increases the risk of ectopic pregnancy and infertility, and the inflammation from gonorrhea also makes a woman more vulnerable to getting HIV.
And what's the standard treatment now, especially with gonorrhea being so resistant?
For chlamydia, it's pretty simple. Doxycycline for a week or a single dose of azithromycin. But for gonorrhea, because of resistance, dual therapy is required. That's a shot of ceftriaxone plus oral azithromycin taken at the same time. And of course, all partners must be treated, and annual screening is a must for sexually active women under 25.
Which brings us directly to pelvic inflammatory disease, PID. This is a serious inflammatory condition of the whole pelvic cavity.
PID is a major threat to reproductive health. It's usually polymicrobial, started by chlamydia or gonorrhea. And the consequences, as we said, are tubal scarring, a huge risk of ectopic pregnancy, infertility, chronic pain, and even a tubo-ovarian abscess, which is a surgical emergency.
The pathophysiology described in Figure 51.1 shows different ways it can spread.
That's right. The most common way is for organisms to just ascend from the vagina, but how they ascend can be different. Gonorrheal infections tend to spread rapidly up through the uterus and into the tubes, and they're usually bilateral. But bacterial infections after something like childbirth might spread more slowly through the tissues and lymphatics and tend to be unilateral.
And what's the key diagnostic sign a clinician is looking for on a pelvic exam?
So the symptoms are things like vaginal discharge, pelvic pain, fever, malaise. But the single most important diagnostic sign on exam is intense cervical motion tenderness. If moving the cervix during the bimanual exam causes pain, that is a huge red flag for PID.
Management is aggressive, broad-spectrum antibiotics. But when does a patient absolutely need to be hospitalized?
The criteria are pretty clear. If you think it could be a surgical emergency like appendicitis, if the patient is pregnant, if they can't tolerate oral meds because of vomiting, if they're severely ill with a high fever, or if you know there's a tubo-ovarian abscess, in those cases, they get admitted.
And the nursing management, especially the education piece from Chart 51-3, is so important for the long term.
It is life-saving. Beyond just managing pain and monitoring vitals, you have to focus on preventing reinfection. But most critically, because PID scars the fallopian tubes, you must explicitly teach patients the signs of a future ectopic pregnancy. You tell them. Severe abdominal pain, abnormal bleeding, a late period feeling faint, shoulder pain, any of that, you go to the ER immediately. That education can save their life.
Okay, let's switch gears from infections to structural problems. Let's talk about fistulas, these abnormal openings between organs.
Right, a fistula is just an abnormal tunnel. The most common are vesicovaginal, which is between the bladder and the vagina, and rectovaginal, between the rectum and vagina. In developed countries, they're usually caused by trauma from pelvic surgery, a difficult delivery, or from radiation therapy.
And the symptoms from these must be just devastating for quality of life.
Oh, they're devastating. A vesicovaginal fistula means a constant, involuntary leakage of urine into the vagina. A rectovaginal fistula means fecal incontinence, passing gas through the vagina, and a terrible odor. It leads to skin breakdown, hygiene nightmares, and profound social isolation.
How do you diagnose a vesicovaginal fistula? It seems like it could be hard to find.
The standard test is the tampon test. You instill methylene blue dye into the bladder and place some packing in the vagina. If that packing turns blue, you've confirmed the fistula. Then you'd use imaging to find its exact location before you attempt a surgical repair.
If you're trying non-surgical management, what's the nursing focus?
It's really intensive. It's all about meticulous skincare to prevent excoriation. For a rectovaginal fistula, you'd use a low-residue diet and intestinal antibiotics to try and reduce fecal contamination of the tract and let it heal.
Right, let's move on to pelvic organ prolapse, cystocele, rectocele. These are super common and result from a breakdown of the pelvic support structures.
Exactly. It's a weakening of the pelvic floor muscles and ligaments. The biggest causes are age and the strain from multiple vaginal deliveries, all made worse by the tissue changes of menopause.
Let's clearly define the different types, because the symptoms are really specific to what's bulging.
Okay, so a cystocele is the bladder bulging down into the front wall of the vagina. So your symptoms are all urinary pressure, incontinence, urgency. A rectocele is the rectum bulging into the back wall. That causes problems with bowel movements, constipation, pressure, sometimes needing to manually splint to have a bowel movement. And then uterine prolapse is the uterus itself descending down into the vaginal canal.
For mild cases, the first line, non-surgical treatment, is always Kegel exercises.
Always. And the nurse has to teach the technique perfectly. It's about squeezing the paravaginal muscles and anal sphincter without using your abs, thighs, or glutes. You hold for 10 seconds, relax for 10 seconds, and do that 30 to 80 times a day. Consistency is everything.
And if exercises aren't enough, a pessary might be an option.
A pessary is a little silicone device shaped like a ring or a donut that you insert into the vagina to physically hold the organs up. It needs to be removed and cleaned regularly to prevent pressure sores or ulcerations on the vaginal walls.
Now, for surgical management, we have to talk about the huge safety alert regarding surgical mesh.
This is a critical point. For a while, synthetic mesh was used to reinforce these repairs, but it was causing major complications, erosion, severe pain. So the FDA actually ordered manufacturers to stop selling transvaginal mesh for prolapse repair. Now surgeons rely on native tissue repair techniques.
So for that surgery, let's talk about the specific post-op nursing care. It seems really specialized.
It is. Pre-op, for a rectocele repair, you'll need a bowel prep. In the OR, a key safety point is moving both legs into and out of the lithotomy stirrups at the exact same time to prevent strain or nerve damage.
And post-op, it's all about preventing pressure on that suture line and managing bladder function.
Voiding is critical. After a cystocele repair, swelling can block the urethra. If the patient can't urinate within about 6 hours, you have to catheterize them. They might even go home with a catheter for a few days. Perineal care is meticulous, gentle cleaning with sterile saline after every time they use the bathroom.
And what about comfort measures, like an ice pack?
For comfort, you can use an ice pack, but, and this is a key detail, the weight of the ice pack has to rest on the bed, not on the patient, to avoid putting pressure on the repair site. And for any posterior repair, stool softeners are mandatory. You have to prevent straining at all costs.
And what are the big take-home points for discharge teaching?
It's all about no straining. No heavy lifting, no straining for bowel movements, no intercourse until the doctor clears them. And they need to avoid prolonged standing or sitting because of the risk of VTE, of blood clots.
Okay, moving on to section 4, benign disorders. Let's start with the vulvovitis and the chronic pain syndrome, vulvodynia.
So vulvitis is usually just simple inflammation from an irritant. But vulvodynia is this really frustrating chronic pain syndrome. It's burning, stinging, sharp pain, often triggered by pressure, which makes intercourse or even using a tampon impossible. Treatment is often multidisciplinary because the cause is often unknown.
And Bartholin cysts are the most common vulvar issue. You mentioned they can be drained with something called a word catheter. What's the goal of that procedure?
The goal isn't just to drain the abscess, it's to create a new permanent drainage tract. A small incision is made, the word catheter is inserted into the cavity, and a little bulb on the end is inflated with water.
And how long does that have to stay in?
It stays in place for 4 to 6 weeks. That long time allows a new permanent duct to form around the catheter, which prevents it from recurring while saving the gland.
Okay, let's move inside now to ovarian and uterine masses. Ovarian cysts are common, but they can be tricky.
They're often benign and related to the menstrual cycle, but, and this is a huge point, any palpable cyst or ovary in a postmenopausal woman has to be investigated for cancer. And a ruptured cyst can cause sudden, intense pain that mimics appendicitis or an ectopic pregnancy.
Then we have Polycystic Ovary Syndrome, PCOS, which is a really complex endocrine condition.
PCOS is all about a disruption in the hormonal feedback loop. The core issues are chronic anovulation, so irregular periods, and hyperandrogenism, or excess androgens, which causes things like hirsutism and acne. It's often driven by insulin resistance, which leads to infertility and the formation of all those little cysts on the ovaries.
And why does PCOS carry such serious long-term health risks beyond just reproduction?
Because of the chronic anovulation, you get chronic, unopposed estrogen stimulating the uterine lining. That dramatically increases the risk for endometrial hyperplasia and even endometrial cancer. And on top of that, the insulin resistance and obesity put them at a much higher risk for type 2 diabetes and heart disease.
So management has to tackle that whole cascade.
It does. Lifestyle modification is number one. Just a 5 to 10% weight loss can be enough to restore ovulation sometimes. Pharmacologically, we use oral contraceptives to regulate periods and protect the endometrium. Metformin helps with the insulin resistance. And if pregnancy is the goal, we use clomiphene to stimulate ovulation.
Okay, next up, uterine fibroids, or leiomyomas. Incredibly common benign tumors.
They're just benign tumors from the smooth muscle of the uterus. They're extremely common, especially in African American women. And they're classified by where they are: intracavitary in the lining, intramural in the muscle wall, or serosal on the outside. They are estrogen dependent, which is why they can have a growth spurt right before menopause.
And while they're often asymptomatic, when they do cause symptoms, it's usually bleeding in bulk.
Exactly. They can cause really heavy bleeding menorrhagia, which can lead to severe anemia. And their size can cause pressure on the bladder or rectum, leading to pelvic pain, backache, and constipation.
Hysterectomy used to be the only answer, but now there are a lot of alternatives to preserve the uterus.
A lot. You have less invasive surgeries like hysteroscopic resection or laparoscopic myomectomy. And then you have a major non-surgical option called uterine artery embolization, or UAE.
How's that work?
An interventional radiologist injects tiny particles into the arteries that feed the fibroid, which cuts off its blood supply and causes it to shrink. It's effective, but there are some rare but serious risks.
Yeah.
We can also use GnRH agonists like Leuprolide to shrink them before surgery.
But those GnRH agonists are only a short-term fix, right?
Right. They create a temporary medical menopause.
Yeah.
So while they shrink the fibroids, they cause major side effects like hot flashes and, most importantly, bone density loss. So you can only use them for a few months.
And finally, for benign conditions, endometriosis. This is endometrial tissue growing outside the uterus, and it's a huge cause of pain and infertility.
The main theory is retrograde menstruation, where endometrial tissue flows backward through the fallopian tubes and implants on the ovaries or other pelvic organs. This tissue then bleeds every month with the menstrual cycle, which causes intense inflammation, scarring, adhesions, and these chocolate cysts full of old blood on the ovaries.
And the symptoms are pretty characteristic.
The hallmarks are severe, crippling dysmenorrhea, chronic pelvic pain, and painful intercourse. The adhesions are what lead to infertility. Diagnosis is confirmed and staged with a laparoscopy.
Management involves hormonal suppression and sometimes surgery. What are the hormonal options?
The goal is to suppress the cycle, so you can use oral contraceptives, or, for a more powerful suppression, GnRH agonists, which cause that temporary menopause. Another option is Damazole, a synthetic androgen, but it has side effects like weight gain and acne. Surgery can be used to destroy the implants, but a total hysterectomy is the only definitive cure.
And the nursing role here must involve a lot of psychosocial support.
Oh, a huge amount. The emotional toll of chronic pain and an infertility diagnosis is massive. Nurses have to provide pain management support and really validate what the patient is going through.
Okay, that brings us to Section 5, malignant conditions and major surgeries. Let's start with cancer of the cervix. The incidence has dropped because of pap smears, but it's still a major risk.
The risk factors are almost all linked to chronic infections, specifically with high-risk HPV types 16 and 18. Other big factors are immunosuppression like HIV, smoking, and an early age at first intercourse.
And survival really depends on catching it early. What are the late-stage signs versus the early ones?
Early on, it's almost always asymptomatic. The first sign is often a thin, watery discharge. As it progresses, the classic symptom is abnormal bleeding, either irregular bleeding or, very commonly, postcoital bleeding, so bleeding after intercourse. Advanced disease is signaled by things like a dark, foul-smelling discharge and severe back and leg pain.
So management really depends on whether it's pre-invasive or invasive.
Absolutely. For pre-invasive lesions, the treatments are conservative. Things like cryotherapy, laser therapy, or a LEEP procedure, which shaves off a thin layer of abnormal tissue. If childbearing is complete, a simple hysterectomy might be the choice.
But for invasive cancer, the treatments get much more complex. We're talking major surgery.
Right. The spectrum goes from a total hysterectomy to a radical hysterectomy, which removes a lot of surrounding tissue and lymph nodes. And then the most extreme procedure is a pelvic exenteration.
That's the one where you remove everything, right? The bladder, the rectum.
Everything. The uterus, ovaries, tubes, bladder, and the rectum. The patient is left with urinary and/or fecal diversions. It's a massive, life-altering surgery reserved for very specific cases. Radiation is also a huge part of treatment, either external beam or internal brachytherapy.
Let's move to cancer of the uterus, or endometrium. This is the most common gynecologic cancer in the U.S.
And the biggest risk factor, as Chart 51-7 shows, is chronic, unopposed estrogen exposure. This is why obesity is such a huge risk factor. Excess fat tissue converts other hormones into estrogen, which constantly stimulates the endometrium. Other risks are age over 50, nulliparity, and taking tamoxifen for breast cancer.
And what's the cardinal symptom that should send up a red flag immediately?
Any irregular bleeding in a postmenopausal woman, period, that has to be investigated, usually starting with an endometrial biopsy. Management is surgical staging, which is often curative if you catch it early. It involves a hysterectomy, BSO, and lymph node sampling.
Okay, cancer of the vulva is much rarer, but it sounds like diagnosis is often delayed.
It is. It's most common in older women. And the most common symptoms are long-standing pruritus itching and soreness. Because it can look like a simple rash, any persistent lesion has to be biopsied.
And management can involve a vulvectomy, removal of the vulva. The post-op care for that sounds incredibly demanding.
It is. Post-op pain control is a huge priority, and positioning is key. You have to avoid any pressure behind the knees to prevent blood clots. Wound care is meticulous with frequent dressing changes, and you have to address the profound body image and sexuality concerns that come with it.
The quality and safety alert in the chapter mentions hemorrhage as a big risk.
It is. The pelvis is very vascular, so nurses have to be watching constantly for signs of hypovolemic shock, a drop in blood pressure, a rising heart rate, low urine output.
Okay, before we get to the big one, ovarian cancer, a quick note on cancer of the vagina and fallopian tubes.
Vaginal cancer is very uncommon. A key risk factor is chronic irritation from a neglected pessary. Fallopian tube cancer is the rarest of all and almost always diagnosed late.
Which brings us to ovarian cancer, the silent killer. It's the deadliest GYN cancer because it's found so late.
That's right. About 70% of cases are diagnosed at stage 3 or 5 because the early symptoms are so vague and nonspecific. We're talking about things like bloating, pelvic pressure, vague GI upset. They mimic everyday benign issues.
So what's the one critical assessment point for nurses to remember?
A palpable ovary in a postmenopausal woman is never normal. It must be aggressively investigated. That is a huge red flag.
And while family history, like BRCA mutations, is a big risk, there's a fascinating preventative measure.
Yes, long-term use of oral contraceptives for 5 or more years can reduce the lifetime risk of ovarian cancer by up to 50%. It's thought to be related to suppressing the constant cellular activity of ovulation.
Management is aggressive surgery and chemotherapy.
It is. The surgery involves a hysterectomy, BSO, and maximal tumor debulking, getting out as much of the cancer as possible. Then that's followed by chemo, usually a combination of paclitaxel and carboplatin. Nursing care in advanced disease often involves managing things like ascites and pleural effusions.
Okay, let's wrap up this section with the most common major GYN surgery, hysterectomy. Let's review the nursing process.
So a hysterectomy is the removal of the uterus. The big post-op risks we manage are infection, hemorrhage, VTE, blood clots, and bladder dysfunction.
Let's focus on VTE and the bladder.
VTE prevention is paramount. So you're using anti-embolism stockings, SCDs, and getting the patient up and walking early. Bladder dysfunction is also really common. We monitor their INO very closely, and if they can't void, we have to catheterize them to prevent bladder damage.
And there are huge psychosocial aspects to this surgery as well.
Huge. You have to proactively address fears about loss of femininity or changes in sexual function. You reassure them that orgasm comes from clitoral stimulation and won't be affected. And you have to allow them to grieve the loss of childbearing potential, even if they were already postmenopausal.
The chapter has a really interesting research note in Chart 51-9 about learning needs based on the surgical approach.
That study was fascinating. It found that women who had a robotic hysterectomy actually had more intense learning needs at discharge than women who had the traditional open surgery.
That's so counterintuitive. The less invasive surgery needs more teaching.
It is. The theory is that because they feel better faster and go home so quickly, they haven't had the time in the hospital to process the surgery. So nurses have to be extremely proactive with discharge teaching for those patients, ideally starting before the surgery even happens, to make sure they understand their limitations and what to watch for at home.
Our very last topic is radiation therapy, specifically internal radiation or brachytherapy.
Brachytherapy is when you place radioactive sources right next to the tumor. Applicators are inserted in the OR while the patient is under anesthesia.
And the critical safety procedure for the staff is something called afterloading.
Absolutely. The applicators are placed and their position is confirmed with X-rays. But the radioactive material itself is only inserted or afterloaded after the patient is back in her private, isolated room. This minimizes radiation exposure for all the staff.
And what are the key nursing responsibilities during that isolation period?
The patient is on strict bed rest in a private room. We have to follow all the radiation safety protocols: time, distance, shielding. We're managing a urinary catheter, and there's vaginal packing in place to push the bladder and rectum away from the radiation source. And all the while, we're providing emotional support to a patient who is physically confined and all alone.
Wow. We have covered the entire scope of Chapter 51. We went from infections and pH balance through structural repairs, benign conditions, and all the way to these incredibly complex malignancies. I think the key takeaway for anyone studying this has to be recognizing that pattern of care. You identify the problem, you minimize the risk factors, and you provide meticulous patient education. And you always have to be aware of how vague symptoms, like bloating, can signal something life-threatening.
That's it. And if you connect that to the big picture for a nursing student, the one skill that comes up over and over in this chapter is comprehensive assessment and truly personalized teaching. Whether you're dealing with vulvovaginal pain or a post-exenteration patient, you have to be able to address the physical symptoms and the deep psychosocial distress, the fear, the loss of fertility, the impact on sexuality. That's holistic care. And to leave you with a final thought, we noted that long-term use of oral contraceptives significantly reduces the risk of ovarian cancer. We also know HPV vaccination prevents cervical cancer. So given all that, how might our societal view of hormonal birth control evolve? Maybe from being just about reproductive planning to being a critical, recognized tool for systemic gynecologic cancer prevention.
Thank you for joining us for this deep dive. Go make those clinical connections.